Welcome to the deep dive. We're here to drill down into some really dense source material and hopefully give you that clear, critical understanding you need.
That's the goal.
And today,
Mhm.
wow, we are wrestling with a topic that really defined the COVID-19 era for, well, billions of people.
Mhm.
The huge controversy around vaccine mandates, those verification systems, passports, all the restrictions that came along with them.
Yeah, it was an incredibly polarized time. Panic, really strong policy decisions being made under pressure.
It really felt like an inflection point, didn't it? Where, public health goals just slammed right into these deeply held ideas about personal freedom.
Absolutely. And what we found, looking through all the sources, legal analysis, ethicists, reports from service providers on the ground, is that this wasn't just random shouting.
Right.
There was a structure to it. It revolved around 5 distinct and, frankly, incredibly complex ethical dilemmas.
Okay, so that's our mission for this deep dive. We're not here to say mandates were good or mandates were bad.
No, definitely not taking sides.
Our goal is to help you understand the actual structure of the arguments.
Uh-huh.
We want to map out those conflict points using this clear 5-part ethical framework you mentioned.
Exactly. And these 5 categories, they really emerged from looking at the core challenges that governments and healthcare systems worldwide were facing. They sort of map the journey of vaccination policy, ethically speaking.
Okay, what are they?
So first, there's the production issue, getting safe, standardized vaccines made in the first place.
Right. Basic safety.
Second, vaccine supply. Availability, how it's allocated. Huge issue.
We definitely saw that play out.
Third, fairness. How do you distribute the limited supply? Who gets prioritized?
The equity question.
Fourth, the big one, the significance of autonomy. That tension between individual choice and what's good for society.
The core conflict, really.
And finally, number 5 is accountability. That covers everything from information reporting to, crucially, maintaining public trust.
Okay. And I think, when you look back at just the sheer scale of the crisis,
Yeah.
it makes it a bit easier to understand why policymakers felt such immense pressure to reach for these really aggressive, mandatory kinds of solutions.
Oh, absolutely. I mean, the World Bank estimated the economic and social damage was just enormous. Globally, only the 2 world wars and the Great Depression caused bigger disruptions in the last, century and a half?
That's staggering context.
It is. And you had millions of reported deaths globally by early 2022, this constant fear of new, maybe more lethal variants popping up. So the drive to use mandatory vaccination, it wasn't just politics. It felt like a desperate search for some kind of control, some way to impose order on the chaos.
Okay, let's unpack this framework, starting with that first pillar. Safe and standard vaccine production. Now, on the surface, this sounds straightforward, right? Science makes sure it's safe.
You'd think so.
But the sources show the speed of development really turned this into a huge ethical problem around public confidence. What were the main worries driving that initial hesitancy we saw?
Well, the ethical requirement here was kind of threefold. You need compliance with strict scientific and ethical rules. You need proof the vaccine actually works, its effectiveness, and crucially, you need to guarantee there aren't severe side effects.
Boy.
But the problem was the timeline. I mean, service providers, the folks on the front lines, they pointed out that using emergency production permits, think Operation Warp Speed in the U.S., and the fact that mRNA technology was so new.
Right, novel technology.
It meant that long-term side effects were, just by definition, unknown. That newness, that novelty, it created this really profound level of uncertainty for a lot of people.
And that uncertainty, well, it directly erodes trust, doesn't it? Which you absolutely need for any big public health campaign to work.
Precisely. And we actually have data that quantifies that anxiety. There were studies showing, for instance, that about 35% of health workers themselves were worried about severe side effects early on.
Wow, even healthcare workers.
Yeah. And in the general population, one analysis found about 26, almost 27%, specifically cited fear of adverse effects as why they were hesitant or refused.
So when governments are asking people, take this new thing for the good of everyone, there's this ethical duty to show the benefits clearly outweigh the risks.
Exactly. And that trust was just really fragile because of that accelerated timeline. It's a tough spot.
Okay, now this is where it gets, I think, really interesting, moving to that second pillar. Vaccine supply and allocation. This wasn't just a logistical puzzle. The sources paint it as a pretty profound ethical failure, exposing these huge gaps in global resource sharing.
Yeah, what really stands out is the shocking scale of the global disparity. The analysis showed high-income countries got 50 times as many vaccine doses per capita as low-income countries.
50 times.
50, 50, even though they only had roughly twice the population. And this led to this, frankly, obscene ethical contradiction where millions of perfectly good doses were just thrown away in wealthier nations.
We're talking huge numbers of discarded doses. Right?
Yeah, massive numbers. I mean, one example, the U.S. alone, by September 2021, had discarded over 15 million doses. They'd expired or just weren't used.
15 million.
And this was happening while low-income countries were absolutely desperate for access. So if the goal was truly global herd immunity, the strategy just felt morally incoherent.
And it wasn't just about having the doses, was it? The pricing itself created another massive barrier, especially for poorer nations.
That's a critical point on the equity front. Pharmaceutical companies, they charged governments globally something like $40 billion above the estimated production cost.
Wow.
And often, low and middle income countries ended up paying significantly more per dose than wealthier nations.
How much more?
Well, think about this comparison. Uganda, a low-income nation, already struggling with its health infrastructure, was paying around $8.50 per dose for AstraZeneca. The U.S., they were paying about $4 a dose for the same vaccine initially.
That's more than double.
Yeah. So, if high-income countries then turn around and start demanding international vaccine passports for travel, well, the ethical justification for that just crumbles when you look at these huge failures in supply and pricing.
Which leads us perfectly into the third pillar, fairness.
Mm-hmm.
So when supplies were scarce, and that was the reality for most of the world for a long time, how did those moral principles clash? You know, utility, getting the maximum benefit versus fairness, making sure everyone gets a shot, especially the vulnerable.
Right. This is the classic ethical tightrope walk of triage, isn't it? Utility says, okay, vaccinate the people who will give society the maximum advantage. Maybe that's the essential workers keeping things running, or maybe the people who spread it fastest, or maybe those who can get back to work quickest.
So focus on function.
But fairness demands something different. It demands equitable distribution, making sure you support the most vulnerable members of society, regardless of their economic contribution.
So if you purely followed utility, you might actually leave, say, the elderly or people with health conditions exposed longer in favor of vaccinating younger, healthier essential workers.
Potentially, yes. That's the conflict. And the sources really stress that if the cost of getting vaccinated, things like transport, taking time off work, any fees involved if that falls entirely on the individual,
Which it often does.
then low-income, vulnerable populations just get automatically excluded. It makes social inequality worse. So the ethical duty of the government was widely recognized as needing to step in, aggressively subsidize, provide free access, actively support these vulnerable groups.
And this wasn't just about being nice. It was essential for public health.
Absolutely. It wasn't charity. It was seen as essential for actually reaching community immunity and bringing down the overall death rate. You can't protect the community if you leave large, vulnerable segments behind.
Can you give us a concrete example? How did a country actually navigate this trade-off when doses were really limited?
Iran is a pretty clear case study discussed in the sources. Because their supply was severely limited early on, they had to be incredibly selective.
Right.
Their initial priority list was very much utilitarian and protective. First, treatment staff got to keep the healthcare system running.
Makes sense.
Then the elderly over 60 and people with underlying diseases the most vulnerable to severe outcomes. Only after those groups were covered did they start moving towards the general, less vulnerable population.
So it shows how scarcity immediately forces these really profound moral choices between, say, saving the system itself versus saving the most individuals right away.
Exactly. It's a brutal calculation sometimes.
Okay, now we're getting into the absolute core of the conflict, the thing that drove so much polarization, the significance of autonomy. Our fourth pillar. This is where individual liberty just runs headfirst into the needs of keeping everyone safe.
Yeah, this is the central tension. I mean, modern medicine's standard ethics, it's built on the idea of individual autonomy, right? Informed consent, privacy, the freedom to choose what happens to your own body.
Bedrock principle.
But public health ethics, especially during an epidemic, it operates a bit differently. It brings in this concept of society autonomy, or sometimes equal respect.
Okay, what does that mean?
The philosophy is basically that during a contagious crisis, your individual right to choose, your autonomy, is ethically limited right at the point where exercising that freedom causes predictable, significant harm to other people.
So the focus shifts. It's not just about treating one patient anymore. It's about protecting the whole community from someone who could be spreading the risk.
Precisely. Things like mandatory quarantine, contact tracing, or, yes, controversially, vaccine mandates, they're all examples where the community's right to safety is prioritized over an individual's absolute freedom. The tricky part, of course, is defining how much harm or risk of harm justifies imposing that mandate.
And legally, the sources point back to a really foundational precedent, right?
Yeah.
Something that gave governments, at least in the U.S., the perceived right to enforce these kinds of measures going back over a century.
That's right. It's the landmark 1904 Supreme Court case, Jacobson v. Massachusetts.
Jacobson, right.
This case upheld the state's right to enforce mandatory smallpox vaccination for adults. Back then, the penalty was a $5 fine, which was more significant then, but still.
Okay.
This case established what's called the government's police power, basically, the authority to enforce public health measures when there's a serious threat.
But hang on, applying a law from 1904 about smallpox, which was, a known killer with a well-established vaccine, applying that to a brand new, rapidly changing coronavirus and vaccines developed under emergency authorization, that caused huge legal fights, didn't it?
Oh, absolutely. That analogy was challenged immediately and fiercely. Opponents argued, look, the risk profile of COVID is different, the novelty of the mRNA vaccines is different, and the consequences for refusing were often way harsher than a $5 fine. People were losing jobs, access to education, social life.
Much higher stakes.
Much higher stakes. But that foundational legal principle from Jacobson that the state can limit individual liberty to prevent the spread of disease that remained the strongest legal pillar supporting mandates, at least in the U.S. context.
So the philosophical justification for forcing, or, well, strongly encouraging vaccination, it really hangs on this idea called the harm principle. How did that frame vaccination as maybe even a moral duty?
Yeah, the harm principle is absolutely key here. The idea is your freedom to act stops when your action creates a real, tangible risk of harming others, especially people who are vulnerable. Ethicists use basically two main philosophical lenses to argue for mandates based on this.
Okay, what's the first one?
First is utilitarianism. This looks purely at the outcomes, the consequences.
Right, the greatest good for the greatest number.
Exactly. So if protecting society, which means saving the most lives, reducing hospital burden, minimizing economic disruption if that requires overriding some individual autonomy through a mandate, then from a utilitarian view, the mandate is justified. It's a cold calculation, maybe, but it's clear.
Okay, consequences justify the means. What's the other lens?
The other is deontology. This focuses more on moral duties and rules, regardless of the outcome.
So less about calculation, more about obligation.
Right. From a deontological perspective, vaccination becomes framed as a moral duty. Refusing to vaccinate, in this view, isn't just a personal choice. It's ethically wrong because it poses an avoidable danger to the collective safety. It moves beyond just weighing costs and benefits and says, look, individuals have an obligation to protect the community, especially in a crisis.
Okay, but this is where I really have to push back a bit, thinking about the opposition's view. If you're, say, a low-wage worker, and a mandate means you either get the shot or lose your job, is that really a free choice? Isn't the threat of losing your livelihood, your ability to feed your family, isn't that just coercion with a different name?
That is the absolute crux of the ethical friction that the sources grapple with. You're spot on. Ethicists often clarify that technically most mandates we saw, like making it a condition of employment or maybe entering a venue, aren't truly compulsory in the sense that no one is physically held down and injected.
Right, you can still say no.
You retain the legal right to refuse. However, and this is the huge however, the penalties attached, like losing your job, facing large fines, being excluded from large parts of social life, they are so severe, so compelling,
Life-altering.
that opponents rightly argue it feels highly coercive. It puts people under duress. So while mandatory vaccination might not be legally incompatible with informed consent, because technically you're consenting to the vaccine to keep your job, the ethical weight of that consent under such pressure is enormous, especially for people who are already financially vulnerable.
Let's tackle the argument that treating people differently based on vaccination status is discriminatory. How did ethicists and legal experts counter that?
Generally speaking, differential treatment isn't considered discriminatory in the legal or moral sense if the characteristic you're basing the treatment on is, 1, modifiable, and 2, directly related to a legitimate goal, like occupational health or safety.
Modifiable, meaning you can change it, unlike race or disability.
Exactly. Unlike innate characteristics like race, sex, or disability, vaccination status is seen as something an individual can change. Therefore, requiring a medical procedure like vaccination for a job that involves, say, protecting vulnerable patients in a hospital is often legally upheld as a reasonable occupational requirement, not discrimination.
But there have to be exceptions, right? What about protected grounds?
Yes, absolutely. Mandates legally must accommodate protected grounds under civil rights laws. The main ones are usually disability if someone has a legitimate medical reason they can't be vaccinated, and often sincerely held religious belief.
Religious exemptions were a huge point of contention.
They really were. However, the sources note that courts, while respecting religious freedom, have often been very careful to limit broad religious exemptions if granting them would pose a demonstrable, significant, and direct risk to public health. The ACLU of Illinois, for instance, supported medical exemptions but argued against overly broad religious exemptions precisely because they could undermine the whole point of the mandate protecting the community. So there's a line, and it's usually drawn, where one person's belief directly endangers the physical safety of others.
Okay, let's put the philosophy aside for a moment and just get into brass tacks. Policy effectiveness. Did these mandates actually work? Did they achieve the goal of getting significantly more people vaccinated? We need the hard data on this.
The answer from the data we have is a pretty clear yes, and the impact was often very rapid. Mandatory proof of vaccination requirements, or the announcement of them, proved to be really effective tools. The time series analysis, particularly from Canada and Europe, is quite robust on this. It shows significant, almost immediate spikes in first dose uptake right after mandates were announced or implemented.
Okay, give us those numbers again. Put them in context.
Sure. So if you look at Canadian provinces that announced mandates requiring proof of vaccination for certain activities,
Right.
they saw, on average, an increase in first dose uptake of about 42% in the first week right after the announcement,
42% jump in 1 week.
compared to the week before the announcement, yeah. And then 71% increase in the second week. What's really crucial here is that often the announcement itself was the trigger. People scrambled to get the shot before the rule actually kicked in.
Scramble effect, right. And the European numbers, I remember those being even more dramatic in some places, showing maybe different cultural responses.
Absolutely. Time series analysis across several European countries showed similar, sometimes even larger, initial jumps. France, with its pass sanitaire, saw about a 17% initial increase. Germany saw a 55% jump. And Italy, which had some particularly strict workplace mandates, saw a really striking 179% increase in uptake right after their announcement.
Wow, 179%.
Yeah. The French policy, the pass sanitaire, is often held up as kind of the definitive case study of a policy that successfully used compulsion or strong pressure to achieve very high vaccination rates, high utility, in ethical terms.
Okay, so there's hard evidence they can be effective. But we always hear this warning about something called psychological reactance. This idea that forcing people can actually backfire, making them dig in their heels even harder or damaging trust for the future.
That is the major counterargument and the significant long-term policy risk. Psychological reactance, it's this basic human tendency to push back when we feel our freedom is being threatened or taken away.
Right. Nobody likes being told what to do.
Exactly. So when mandates feel overly coercive or maybe not fully justified, they can definitely damage public trust. Especially among certain groups, parents were often mentioned in the sources. And this can make people who were hesitant become firmly resistant. They might entrench their opposition and potentially resist future public health measures, even ones that might be more necessary.
So mandates should be the last resort.
Absolutely.
No.
Ethically, policymakers should treat mandates as the absolute last resort only after they've genuinely tried and exhausted less intrusive, more autonomy-centered alternatives.
Okay, so if direct coercion is the, let's say, the nuclear option,
Right.
what are some of these effective nudging alternatives? Things that respect autonomy more, but still push towards the public health goal.
Yeah, behavioral science actually offers a lot of great tools here. One approach is the soft mandate. This tries to mitigate the risk without forcing vaccination itself.
How does that work?
Well, the example often cited is the University of California, San Diego. Initially, they required unvaccinated students to get tested for COVID every single week.
Oh, okay.
So the students kept their bodily autonomy. They weren't forced to get the shot, but they had to bear the burden, the inconvenience of regular testing to ensure they weren't spreading the virus. It protects the community while respecting choice, albeit with a consequence.
And we saw private companies stepping in too, right? Using positive incentives to encourage vaccination, kind of bypassing the need for government mandates sometimes.
Definitely. Corporations used lots of targeted incentives. Target, the retailer,
How?
famously paid its workers for the time it took them to get vaccinated. I think it was 4 hours of pay.
Right.
Lyft offered free rides to vaccination sites, tackling that practical barrier of transportation. But probably the most powerful nudge, according to behavioral science, often comes from just changing the default setting.
The opt-out mechanism. Tell us more about the psychology there. Why is that so effective?
The Rutgers University study on the annual flu vaccine is a classic example here, when they automatically signed employees up for their flu shot, meaning the employee had to actively take a step to opt out if they didn't want it.
Instead of having to sign up.
Right, instead of having to actively opt in, uptake increased by a massive 36%.
36% just by changing the default.
Yeah. It works because, by nature, humans tend towards inertia, the path of least resistance. Setting the healthy choice as the default makes it easier. It lowers the mental effort needed to comply. Even really simple things work. There was a study at a Midwestern utility firm where just asking employees to write down the specific time they plan to get
It's
vaccinated,
just making a plan.
just making that concrete commitment, it increased uptake by a measurable 12%. It makes the intention real.
So you're shifting the burden from, I need to actively decide to do this thing, to, I need to actively decide not to do this thing.
Mm-hmm.
That's quite powerful psychologically.
It really is.
And finally, what about just the power of public messaging? Framing it right to create a sense of community.
Messaging is absolutely vital. It's about framing the action, whether it's vaccination or mask wearing, as something pro-social, something you do for others, rather than just something the government is forcing on you.
Like the Cuomo example in New York.
Exactly. Governor Cuomo's campaign framed mask wearing not just as self-protection, but as an act of respect. I wear a mask to protect you. That messaging aimed to instill a community ethic, a sense of collective responsibility. And we know this resonates because studies consistently showed a large percentage of people who got vaccinated, sometimes as high as 65%, cited protecting others, not just themselves, as a key motivation. People generally don't want to be seen as selfish or uncaring members of their community.
Okay, so the ethical case for mandates seems, perhaps, clearest or strongest in certain specific high-risk settings. Let's talk about healthcare personnel, HCPs, first. Here, the argument seems to go beyond just personal choice. It's framed as a direct ethical obligation to patients, right?
That's exactly right. Healthcare workers operate under a very clear, established ethical duty to avoid causing harm, the principle of non-maleficence, and also to actively protect their patients, many of whom are uniquely vulnerable, maybe immunocompromised, elderly, frail.
So a mandate isn't just about the worker's health.
No. It's justified because lower vaccination rates among staff directly lead to more staff getting sick, which means more staff shortages. That increases the risk of hospital-acquired infections spreading to patients, and it puts immense strain on the whole system's resources.
It's a cascade effect.
It is. One unvaccinated staff member getting sick doesn't just affect them. It can endanger the entire patient population in that facility. This is why mandates for other diseases like measles, hepatitis B, even the annual flu shot have been pretty standard practice in healthcare settings for decades. It's seen as part of the professional obligation.
And yet, even with that strong ethical underpinning, we still saw significant hesitancy, particularly early on, even among people who presumably understood this ethical weight. What were the specific worries fueling that?
Yeah, despite very high overall compliance among physicians, often reported upwards of 96%, there were definitely noticeable pockets of resistance, especially among nurses and other allied health professionals, where hesitancy rates were sometimes cited as high as 33% back in late 2020.
33% is significant.
It is. And their concerns weren't just abstract political objections. They frequently talked about the perceived rushed development, the lack of long-term safety data because of the emergency approvals, and genuine worries about potential severe adverse events. This hesitancy, right among the staff, created the potential for a real moral crisis inside hospitals.
So what happens then if a hospital puts a mandate in place but still faces a large number of staff refusing? The sources talk about this really severe, multi-phase ethical dilemma regarding how you assign staff and care for patients. This sounds like a source of incredible moral distress for administrators and clinicians. Walk us through those phases.
Yeah, this is probably one of the most morally gut-wrenching situations a hospital leader or ethics committee could face. It's laid out in phases.
Okay, phase one.
Phase one is maximizing safety. You do everything possible to ensure that your fully vaccinated staff are assigned to the most critical roles, especially caring for the most vulnerable patients, like those in the ICU or oncology wards. You optimize with the vaccinated staff you have.
Makes sense. What's phase two?
Phase 2 is compromise triage. This happens if you're still short-staffed even after optimizing. You now have to bring in necessary unvaccinated staff to fill critical gaps. But ethically, the guidance suggests they should only care for specific patient groups. The sources often mention assigning them only to other unvaccinated patients who cannot yet be discharged.
Okay, unvaccinated staff for unvaccinated patients.
Right, but here's the profound moral difficulty. Those patients must be fully informed that the staff caring for them are unvaccinated, and they have to be advised of their right to leave the hospital, potentially against medical advice, even if they still need care.
Wow. So you're essentially telling a sick patient, your nurse isn't vaccinated, you can leave if you want, even if leaving is dangerous for them.
Exactly. It's a severe breach of the normal standard of care and the hospital's duty to protect. It creates immense moral distress.
And then there's a phase 3, the point where the system really breaks down.
Yeah. Phase 3, the crisis standard, is the ultimate ethical failure point. This is when the staffing shortage is so severe that the hospital is forced to make even worse choices. Either assign unvaccinated staff to care for vaccinated or critically vulnerable patients, knowingly increasing their risk.
Which completely undermines the point of the mandate.
Completely. Or perhaps even worse, the hospital is forced to actually close needed beds, turn away patients, or discharge patients who still need inpatient care simply because they cannot staff the units safely according to crisis standards of care. At this point, the mandate has failed to ensure safety, and the hospital is operating under conditions of profound moral compromise, potentially sacrificing the well-being of the very patients they exist to serve.
That's a terrifying scenario.
Yeah.
Okay, let's switch gears slightly to the military. Another specialized setting where mandatory vaccination is, well, pretty routine for lots of diseases.
Mm-hmm.
How did the COVID mandate fit into that existing high compliance culture?
The military context is definitely unique because individual autonomy is already significantly curtailed in many ways, always in favor of the mission and unit cohesion.
Right, it's a different social contract.
It is. So the ethical justification for the COVID mandate in the military rested primarily on two types of harm, both directly related to readiness. First, there's the harm of an individual service member becoming infected and posing a direct, potentially high consequence threat to others, especially in close-quarter environments. Think about sailors on a ship, soldiers in a tank, personnel on a forward operating base. An outbreak can quickly render an entire unit combat ineffective.
So it's about immediate tactical failure, losing the capability.
Precisely. And second, there's the broader strategic harm. An unvaccinated force undermines the military's fundamental status as a ready deployable force capable of protecting national security interests at a moment's notice. Unlike in civilian life, where maybe your refusal primarily impacts your immediate circle, in the military, widespread refusal directly degrades the operational capacity and readiness of the entire organization.
Did military leaders just jump straight to ordering the mandate, though? Or did they try those alternatives first, like the incentives and nudges we talked about for the general population?
No, the general ethical principle of using the least restrictive means still applies, even in the military. The standard playbook advises leaders to first try alternatives.
Like what, in a military context?
Things like offering positive incentives, maybe special liberty passes, preferred duty assignments, or removing burdensome travel restrictions or quarantine requirements for those who get vaccinated. And conversely, implementing specific burdens for the unvaccinated, perhaps restricting non-essential travel, requiring regular testing, maybe excluding them from certain desirable training or unit functions.
So carrots and sticks, essentially.
Pretty much. However, the sources generally agree that if these voluntary measures and nudges failed to achieve the vaccination rate deemed necessary for maintaining military readiness and protecting the force, then overriding individual autonomy through a direct mandate was considered ethically justified. It's justified by that paramount need for mission accomplishment and national security, which, in that specific professional context, generally outweighs individual preferences.
Okay, our final pillar is accountability. And this often connects directly to how mandates were enforced, specifically through these vaccine verification systems, or VRVs, often just called vaccine passports. Now, you mentioned earlier the idea of proving vaccination for travel isn't actually new, is it?
No, not at all. That's what's really fascinating. This concept goes way back. The World Health Organization established the paper carte jaune, or yellow card, the International Certificate of Vaccination, way back in 1959 for diseases like yellow fever.
Right. I've had one of those for travel.
Exactly. And paper still serves a really vital function. It works when the internet is down. It's accessible to people who don't have smartphones, which is a huge portion of the global population. And it can serve as a crucial backup even if you have a digital version. And indeed, paper cards were widely issued in places like the US and the UK during the pandemic.
But the big push, the intense focus, quickly shifted to digital passports. They were seen as the modern, more secure, maybe fraud-proof way to verify status. What are the key ethical demands placed on these digital systems when we think about accountability and trust?
Digital apps definitely have the potential to prevent fraud much better than paper, that's true. But they also introduce a whole host of really significant ethical requirements. For them to be accountable and trustworthy, they absolutely must prioritize security, privacy, and transparency.
What does that mean in practice?
It means things like they should only store the absolute minimum data necessary to actually verify vaccination status, nothing extra. They need robust end-to-end security to prevent hacking or misuse. And critically, this is a big one, the system should allow verification without actually sharing the person's underlying personally identifiable information, PII, or their detailed personal health information, PHI, with the person checking the pass, like the bouncer at a club or the airline gate agent. The verifier only needs a yes/no, not your whole health history.
And this issue of privacy, but also accessibility, is exactly why some civil liberties groups, like the ACLU of Illinois you mentioned earlier, even while they generally supported mandates for public health, came out strongly against the digital passport concept. What was their main policy objection?
Yeah, the ACLU's concern was really rooted in two main problems, inequality and the risk of mission creep.
Okay, inequality first.
Inequality, because digital passports instantly create or worsen the digital divide. They automatically exclude people who don't have reliable access to smartphones or the internet. That includes many low-income individuals, sometimes the elderly marginalized communities. Requiring a digital pass essentially creates a barrier to participating in society for those groups.
And the second concern? Mission creep. What's that?
Mission creep is the fear that a system created for one specific purpose, in this case, verifying vaccine status during a pandemic, could easily be expanded or repurposed later for other forms of tracking or surveillance long after the immediate crisis is over.
Like a permanent health surveillance infrastructure.
Exactly. Once you build the technological infrastructure to easily track people's health status, the temptation for governments or even corporations to use that data for other, perhaps less justifiable means becomes really strong. So because of these risks to equality and privacy, the ACLU and similar groups advocated strongly for sticking with accessible, maybe enhanced paper-based systems or other alternatives that didn't rely on technology that excludes people or creates new surveillance risks.
Okay, finally, we have to circle back to where we started almost, connecting this passport issue with that massive failure point we discussed earlier, global health equity, implementing international vaccine passports when vaccine distribution was so incredibly unequal. This seems like perhaps the biggest ethical failure of accountability in the whole story.
It really feels like the ultimate contradiction, doesn't it? By late 2021, estimates were that only about 40% of the entire global population was fully vaccinated. So if high-income countries then turn around and require proof of vaccination for international travel,
You're locking out most of the world.
you are actively restricting the movement and opportunities of the majority of the world's population, particularly people living in low and middle-income countries, LMICs. The data here is just damning. One analysis showed 68% of high-income countries were using or planning travel passports, compared to only about 7% of low-income countries.
So let me get this straight. Wealthier nations largely fail to ensure equitable supply and fair pricing, violating Pillars 2 and 3, fairness and supply.
Correct.
And then they effectively use the resulting vaccine scarcity, which they contributed to, as the justification to restrict travel and opportunities for the very people in poorer nations who couldn't get the vaccine in the first place.
That's precisely the argument made by global health equity advocates. It just massively amplifies existing global inequities. The moral argument against it is crystal clear. Ethically, high-income countries had an obligation to prioritize global collaboration, to actively work to improve access and supply in LMICs, and help stabilize pricing before even considering implementing international travel passports.
Otherwise, you're just creating a two-tiered world.
Exactly. A system of global mobility based not primarily on actual health risks, but largely on economic privilege and geography. It's a profound ethical failing on the accountability front. Hashtag outro, host speaker, and expert speaker.
Wow. Okay, this deep dive has really laid bare that intense, often painful tension at the heart of how we govern pandemics, hasn't it? On one hand, the clear necessity for aggressive public health actions like mandates, which, as the data showed, were demonstrably effective at driving up vaccine uptake and likely saving many lives.
The utility was often high.
But on the other hand, this deeply felt moral imperative to protect individual autonomy, personal liberty, and civil rights. It's a clash of fundamental values.
It really is. And by synthesizing this whole complex debate into those 5 ethical pillars we discussed, safety, supply, fairness, autonomy, and accountability, I think we gain a really crucial diagnostic tool. Well, it allows us, and hopefully you listening, to evaluate future policies not just based on whether they worked in terms of achieving compliance, but by looking closely at the ethical trade-offs and compromises they demanded along the way. The French pass sanitaire is a great example. It achieved high utility, high vaccination rates, but it came at a significant cost to that deeply held value of individual choice for many French citizens.
So the ethical ideal is always to find the least coercive path.
Exactly. Ethically, policymakers should always strive for the least coercive, least restrictive approach that can still effectively achieve the necessary public health goal. That balance is key.
That balance between utility, saving lives, reducing harm, keeping society functioning, and proportionality, making sure the burden placed on the individual isn't excessive or unfair compared to the threat. That seems like the ultimate tightrope walk for successful crisis governance.
It absolutely is. The challenge is always ensuring that the severity of the intervention, like a mandate, is truly proportionate to the immediate severity of the threat. That justification needs to be constantly reevaluated.
Which brings us, I think, to a final, really critical, maybe provocative thought for you, the listener, to mull over. It seems clear that mandatory, population-wide health policies, particularly around vaccination, have now kind of become a normalized part of the pandemic governance toolkit globally.
They're on the table now in a way they perhaps weren't before 2020 for many countries.
Right. So the challenge for policymakers moving forward isn't just about how to achieve high uptake of vaccines or other measures in the next crisis. It's about how to do that while ensuring that public trust in government, trust in scientific institutions, is maintained or maybe even rebuilt throughout the process.
Because if that trust gets seriously damaged, if people feel measures were overly coercive, disproportionate, inequitable, or maybe based on shifting science,
Which backfire later.
it could irreparably hinder people's willingness to adhere to future public health advice or interventions, maybe for the next pandemic, which could potentially be even more dangerous. So here's the question to leave you with. What defines a truly successful public health policy in the long run? Is it simply the one that achieves the highest rate of compliance, the highest vaccination uptake? Or is it the policy that achieves high uptake without fracturing trust, without degrading the social contract that holds society together, ensuring that people are willing to cooperate voluntarily next time?
Achieving the goal versus preserving the foundation for future cooperation.
Exactly. That might be the true measure of long-term preparedness. Something to think about.